It's back to me, Catherine Cannan, the chair of the Southeast Division, and this is for the Southeast Division prize presentations. I want to thank you all for joining this session and to just speak about the 4 prizes that the Southeast Division has. We've got 4 poster prizes and then 1 poetry prize. So we've got 2 divisional poster prizes and 2 FYMS, Foundation Year Medical Student poster prizes. The first goes to the overall winner in each of those categories, and the second goes to the entry that demonstrates, in the eyes of the judges, the greatest innovation or service improvement. And that divisional poster prize has been open to all trainees and specialty doctors who work or live in the Southeast Division area. And the Foundation Year Medical Student poster prize was open to foundation year doctors and medical students who are in training working in the Southeast Division. And the poetry prize, as you know, is open to anyone who has any connection to mental health. So that can be either a provider, a professional, a service user, a carer, someone with an interest. So thank you all, first of all, for your entries. Thanking you for making such a huge effort to get the projects in and for the high quality that they were and the wonderful work they show us that you are doing. The judges for the Divisional Poster Prize were Professor Rafi Faruqi, Dr. Osama Hammer and Dr. Nupur Tiwari. For the FYMS Poster Prize, Dr. Ahmed Hanker, Dr. Raghavendra Ramachandra, and Dr. Akram Wilson. And for the Poetry Prize, Dr. Jess Mukherjee, Dr. Ivana Bialas, and Tanya Lee. So everybody has done a truly amazing job, and we've had quite a process to get the judging done virtually because of the current COVID situation. So for me then, to announce the first winner, congratulations to Dr. Adam White. It's lovely to see you there, and Dr. Helen Lee. The title of their project was Testing the Testers, Survey of Medical Trainees' Knowledge of the Montreal Cognitive Assessment.
So my name's Adam White. I'm an ST5 in General Adult and Old Age Psychiatry, and I'm presenting today with Helen Lee, who's an ST7, also an OA and GA Psych. So just to give an overview of our study, the aims of our study were to investigate how accurately trainees score the MOCA, also known as the Montreal Cognitive Assessment, and to explore whether training has an effect on the scoring of the task. In terms of our method, we showed a mock MOCA to 16 trainees in December 2019 and asked them to score the performance of the mock patient and the mock administrator. We will then analyse the scoring of that group and then repeated the task in January 2020 with 14 of the same trainees after they'd received a training session on both the administration and the scoring of the task. In terms of our results, the correct score in both December 19 and January 20 was 20 out of 30, and in the initial group the scores ranged from 18 to 25, with a mean score of 21.4 and a standard deviation of those scores of 1.73. Then after that training and feedback session, when we repeated the task in January 2020, those scores ranged from 19 to 25, with a much tighter mean of 20.6 and a standard deviation of 1.49. So in terms of our conclusions, our study highlighted that there was a significant degree of variation in accuracy and scoring of the task between trainees, and as such, trainees and supervisors should not take knowledge of the MOCA for granted. And there was an improvement of performance following training, and giving feedback on a mock MOCA interview appears to be an effective intervention for improving trainees' knowledge. In both cohorts, there was a notable difference in that formal experience of training resulted in more accurate results. So we recommend that specific training is considered before trainees administer the task in a clinical setting. So I'm going to hand over to Helen to answer our judges' questions. Over to you, Helen.
Karen, do we have any judges' questions?
Yeah, so I think I'm going to respond to those. Thanks, Adam. So we were asked 3 questions by the judges, and these are our answers. The first question was about how our results compared with other published studies reporting reliability and validity data of the MOCA. So our study isn't one of reliability or validity of the MOCA per se, rather the accuracy with which it is applied by a group of trainees. We're taking at face value the highly replicated findings showing that the mocker itself is both sensitive and specific with a high degree of inter-rater reliability. We think that the most relevant of these to our study is inter-rater reliability, but this is usually a measure of how much agreement there is between two usually highly experienced raters over multiple different applications of a test. So in contrast, our study looked at one application of a test, in our case the mocker, by multiple different raters, and we weren't able to find a study doing a similar thing in the literature. Question 2 was about whether or not we'd expect any differences between the use of the standard mocker and electronic version of the mocker. And as you might expect, at the moment, with remote consultations becoming more commonplace, there's been a lot of interest in comparing paper and electronic versions of many tests. And studies of the mocker have shown a high degree of reliability between the two. We don't think there's a particular reason to suspect that this would be different in our population, though published studies would have used highly experienced raters. Areas of the test which may make for a more accurate score on the electronic version are that the serial 7s task is marked by the device itself, and also the addition of all the sub-scores, including whether or not the patient gets an extra point for education, is done for you in the electronic version. So that eliminates the chance of a simple error of arithmetic in calculating the total score. Other areas of the test are, we think, subject to similar likelihood of errors. In addition, our study only looked at the scoring of the mocker, not the administration of the test. And the electronic version prompts the tester to use the exact wording from the rubric, which may result in more consistent scoring. The third and final question was, had we thought of proposing to include this teaching in the formal teaching programme for trainees? And the short answer to that is yes, we would like to, but there may be legal and financial considerations about this, because mockertest.org, who own the mocker, are requiring that everyone completes their training in the mocker before using it, and that's going to come into place quite soon. Many thanks for listening.
Well, many congratulations, Dr. Helen Lee and Dr. Adam White. Wonderful to hear you present your work personally and answer those really difficult questions really, really well. So I'm very impressed, and you're very worthy winners. Thank you.
Thank you, Catherine. I would now like to award the prize for the entry that demonstrated the greatest innovation or service improvement in the divisional poster category. Dr. Ben Thompson, use of virtual speech and language therapy in a low secure autism ward. Dr. Thompson identified speech and language therapy, SLT, as a fundamental treatment for treatment with autism and plays a vital role in his secure service. Speech and language therapists are hard to recruit across the UK, and with the advent of the COVID-19, innovative ways of dealing with this problem needed to be established. And his project has looked at virtual ways of providing speech and language therapy. I will now hand you over to Dr. Thompson, who will give you a 5-minute presentation on his project.
Hi there, my name is Ben Thompson and I'm a specialty doctor working at Park Hospital. I currently work on an acute medium secure ward, low secure ward autism. So this project's been focused on the autism ward. So with the stresses experienced through social distancing, PPE, cancellation of leave, general uncertainty, these stresses have arguably taken a greater toll on individuals with autism. So the need for effective therapy has been greater than ever, and we've been forced to think innovatively around providing services. To overcome some of these complexities, we've been trialling the use of remote technology to deliver speech and language therapy to several of our patients. Feedback from the patients has been extremely positive, as seen in the poster, and overwhelmingly patients feel they can get their views across effectively. There's limited frustration, sound and video quality has been good, and most would recommend to a friend. However, there's a clear pattern that patients did actually miss the human interaction and would like to continue face-to-face sessions after COVID. So on to some of the questions. Did we use any outcome measures during this work? So with regard to outcome measures, there's a communication checklist self-report. This is a measure used by the speech and language therapist for her general work. She uses pre and post assessments for these measures. However, for this poster, these measures weren't used, as the work she's been doing is over the last year or so, and the work's been a mixture of face-to-face and then more recently the remote sessions, so that these measures don't really reflect the remote working, but it's something to look towards going forwards. Question 2, the virtual sessions were positively perceived and the patients are missing the face-to-face contact. What's the criteria used to establish the use of face-to-face contacts after the easing of the pandemic? So I think this is a really tricky question. I think that reintroduction of the face-to-face working will be dependent on a lot of different factors. Factors such as COVID restrictions, PPE guidance, availability of therapists, what the patient feedback is, and then the clinical rationale. So we feel this poster highlights that the remote working can be done and that there's many benefits, which I can discuss, but there's more work needed around the efficacy of the remote work, which links to the previous question. Question 3, do we feel a combination of face-to-face and video sessions is the way forward post-COVID? So yes, going forwards, the plan is to continue with the combination. The remote therapy has prompted the use of more interactive resources and the use of technology within the sessions, and patients have reported really enjoying these elements. Whilst the remote therapy initially seemed to be a contingency tool, the positive effects have suggested utility in permanent practice. So to summarise, we feel these sessions have been positively received by patients. There's numerous cost and time benefits, such as reduced travel costs, more efficient use of office space, and flexibility around working. And then just finally, I found the feedback on the missing the face-to-face contact really interesting, particularly given that many of our ASD patients claim to dislike human interaction. The results were the opposite, and we feel this kind of supports the hypothesis that humans are social beings and have an innate need to connect with others, perhaps ASD or no ASD. Further to this, a lady called Kerry-Ann Morrison and her colleagues looked at real-time social interactions of 67 autistic adults and 56 typically developing adults in a study. And the results showed that while autistic adults were perceived to be more awkward, less warm, and less attractive compared to typically developing partners, it found that the researchers found that the autistic participants reported feeling much closer to their social partners. There could be multiple possible explanations for this, but one may be that the autistic people valued social interactions more, especially when given that chance to socialise. So thank you very much.
Thank you, Dr. Thompson. This was a really interesting presentation. I have been informed by the judges that the entries this year were all of an exceptionally high standard and that they wanted to award judges' certificates for the second and third place. I would like to inform you that the second place went to Dr. Shah Tarfosha on his entry, Patient CV, Increasing Productivity of On-Call Junior Doctors and Site Managers in a High Secure Forensic Hospital throughout the process of task automation. And the third place went to Dr. Charlotte Jones and Dr. Abigail Hood on their entry entitled The Physical Healthcare of Patients in Secure Hospitals, Setting Standards for Medical Equipment. I would now like to award the overall winner's prize for the Foundation Doctor Medical School for the FYMS Poster Prize category. This has been awarded to Dr. Ka Long Au for his entry, Schizophrenia and COVID-19, Are Standards Being Met During the COVID-19 Pandemic? Closed Loop Audit. Dr. Au addressed the adherence to the recommended standards of care in the management of patients with schizophrenia to see what impact COVID-19 had on these standards. I'll now hand over to Dr. O, who will give you a 5-minute presentation.
Hi, I've conducted an audit to investigate how the management of schizophrenia patients have changed during the COVID-19 pandemic. So just a bit of background about this topic. The COVID-19 pandemic has raised questions regarding the adherence to standards in the provision of care to patients with schizophrenia. So the things which may be affected by COVID include infection control, which may play a role in physical health monitoring, and the high turnover of staff caused by redeployment, and also self-isolation, meaning some services like psychological services may have to work from home. So the standards we looked at were firstly antipsychotic prescription. Basically, one of the things we are looking at here is whether or not we are trying two different classes of antipsychotics before switching to clozapine. Because based on the KD study, we should try both first and second generation before switching, because there's no consistent overall benefit of either one of those classes. And physical health monitoring, according to RC Psych, it's been shown that poor physical health in people with psychosis may lead to reduced life expectancy by 20 years. And the other two standards we looked at were involvement of patients in their care and also access to psychological services. So in terms of methods, first cycle was done in the beginning of August, and the retrospective data was collected from the inpatients with schizophrenia admitted after March. The second audit was repeated in mid-November time. So in general, there's high adherence to antipsychotic prescription. I just want to highlight an area with reduced adherence. It's the investigation of the cause of lack of symptomatic response in non-clozapine antipsychotics. On the other hand, here's what's interesting. Whenever clozapine was found to be inadequate in symptomatic response, there was 100% adherence in investigation. So this may be due to biased thinking. If clozapine doesn't work, it's likely due to non-adherence or substance misuse, not because of it being non-efficacious. So this is just something to think about. Now, we've also included a section in the What Round Pro Forma document as intervention to remind ourselves to do this whenever a patient is not responding to an antipsychotic. And a slight improvement was seen in the second cycle. Patient involvement in decision of care was excellent for both cycles. And in terms of physical health monitoring, there was poor adherence. In terms of interventions, we have circulated emails emphasizing the need to record negative findings. So for example, if a patient doesn't have a family history of diabetes, we should write down no family history of diabetes. The second audit cycle demonstrated general improvement across all domains of physical health monitoring. Waist measurement recording was still lacking, and we designed a pro forma document for waist measurement. In summary, the closed-loop audit showed that investigation of inadequate symptomatic response to non-clozapine antipsychotic remains low in the second cycle. Physical health monitoring could still be improved on, and patient involvement in their care was excellent. We plan to include a section in the What Round Pro Forma document to remind ourselves of the need to investigate antipsychotic prescription. We would like to continue to include all negative findings in monitoring and the use of new waist measurement pro forma document, and we plan to re-audit this in 6 months' time. Now, in terms of the judges' questions, here they are. For the first question, I think standards are particularly reduced for schizophrenia compared to other serious mental illnesses because patients with schizophrenia, they often lack insight and they become reluctant in physical health monitoring. Furthermore, psychotropics are more commonly used in patients with schizophrenia, so there's more stringent guidelines in physical health monitoring for this group. It is therefore more challenging to be adherent to standards for schizophrenia management than other serious mental illnesses. Second question. So yes, staff shortages definitely played a role. Over the past 2 months, the staff turnover rate has been higher. There have been more agency nurses working on the ward, and very often they're unsure of the ward protocol. So to overcome this, the physical health monitoring pro forma that I designed has been placed in the treatment room with clear indication on what needs to be done and on which patient. So there seemed to be an improvement across each domain on the second audit cycle. So I think it worked. And third question. Yes, this is an inpatient-based audit, and a similar audit can and should definitely be done in community setting. Apart from COVID-19, there were other barriers in adhering to standards. I think particularly in physical health monitoring, patients often refuse bloods, ECG, and other domains which require regular monitoring. And finally, there are figures from several papers on physical health monitoring in the outpatient setting, and these studies had heterogeneous data collection methods, so it is very difficult to compare data. But the general trend in the papers is that physical health monitoring is lacking in adherence. So I understand there is a concern that this audit has no benchmark figure to compare with, but the hospital I've conducted my audit on is known to be very adherent to standards, and we hypothesized initially that COVID has caused reduced adherence, and the first cycle showed reduced adherence. And our interventions targeted COVID-related changes such as new staffing, infection control, and our results did show improvement. So it is likely that COVID has indeed caused reduction in standards. And we also plan to re-audit this in 6 months' time to consolidate this hypothesis. Thanks for listening.
Thank you, Dr. Al. That was a very fascinating and thought-provoking presentation with very interesting results. A worthy winner for this award. Again, the standards this year for each entry was exceptionally high. So once more, we would like to award the judges' certificates for the second and third place. In the second place was Dr. Paras Agarwal for their entry entitled Neuroleptic Malignant Syndrome on Clozapine Monotherapy, a case report. In the third place to Dr. Imogen Rees on her entry entitled Vitamin D Monitoring and Replacing on Older Persons with in Psychiatric Wards. Thank you all for all the entries submitted this year, and I'm sure you will agree that it's amazing to see what wonderful work trainees and junior doctors are undertaking in the division. I will now hand you back to Professor Kenan.
We do have our prize recipients for the next award, and this is for the FYMS Poster Prize, showing the greatest innovation of our service improvement. So I'm delighted to say the winners are Dr. Ann Chow and Dr. Sangeeta Mack. So well done, both of you. And I believe now you are ready to give us a brief overview of your project, and I'm handing over to you for that.
Thank you very much. We're Sangeeta and Anne. We're two FY1s in older persons mental health. We're currently based at the Western Community Hospital in Southampton. The two wards we work on focus on organic and functional mental health disorders. Our project focuses on the implementation of the Treatment Escalation Plan Performer, or TEP. Before implementation, every patient was escalated to Southampton General Hospital when unwell, regardless of their background. During the COVID-19 pandemic, we realised the importance of knowing a patient's feeling of care, especially in this category of patients who may have multiple comorbidities and frailty. At the bottom of our poster, you can see the TEP Proforma, which has been adapted from the one used at Southampton General Hospital. TEPs are formalised documents detailing the ceiling of care for a patient in case of clinical deterioration. In understanding the importance of co-production, patients with capacity were included in the discussion of their TEP form. If not, a discussion with their legal next of kin was had. Similar to a DNA CPR, this was ultimately a medical decision. This is beneficial to support patient-centred care. A barrier to this is possible compromise to the doctor-patient relationship due to conflict regarding the decision. Our aim was to tailor the TEP Proforma to a community mental health setting, increase awareness of the TEP form and its usage. We improved the Proforma to expand on the ward-based option based on the medical care our community hospital can provide. Moving on to methods, we collected qualitative and quantitative data from the multidisciplinary team. We created a 7-point questionnaire, which was a mix of open and closed questions, including the following: what was the TEP, whether they felt it was comprehensive enough, how locatable was it on the ward, and how comfortable did they feel discussing this with next of kin. The closed questions were scored on a scale from 1 to 5, 5 being strongly agree. A similar questionnaire was given to next of kin with 5 questions on it. Quantitative data was collected on how many days from admission it took to fill out the TEP form, who was contacted, the decision of the TEP, and its documentation on the electronic system RIO.
This was a quality improvement project piloted in June 2020, with the first cycle of results collected, re-looked at in August and September with further evaluation, and a snapshot done in November. Our results show 100% of inpatients now have a TEP form easily locatable in their files. There is now a protocol in place to include filling out a TEP form as part of the admission clerking. The forms are placed at the front of the patient's paper notes, just behind the DNA CPR form if present. There was slight resistance from the MDT in terms of understanding the need and usage of a TEP, though after explanation, all members are in agreement that a formalized TEP is vital. MDT understanding of TEP forms increased by 40% from a rating of 3.5 to 4.9, and their views on TEP's comprehensiveness by 77%, 2.6 to 4.6. Time to complete TEP form from date of admission decreased by 55% from 7 days to 3.2 days, which demonstrated the success of including it as part of the admission clerking, as well as an increase in junior doctors' confidence to discuss it with patient or next of kin. No service user expressed unwillingness to engage in the discussion. Patient next of kin's understanding and desire to have a formalized TEP was 96%, rated 4.8 out of 5. 90% of patients were for full escalation, 10% were for ward-based care, and none for palliative care. This data suggests that the majority of our patients are being fully escalated, and further discussion will need to be had with the medical team as to whether or not this is the best management option. Having a TEP form in place had a clinical impact for the 2 patients on ward-based care, highlighting the limitations of their treatment. In conclusion, TEP forms were successfully implemented in our community mental health hospital, and we plan to do further research into how this has impacted care. Qualitative data showed improved understanding by MDT members and next of kin, although a formalized teaching session would prove beneficial. We intend to roll out the TEP form across our mental health trusts and share findings nationally to promote best practice. We hope you enjoyed listening to our virtual presentation. Thank you for your time.
Thank you very much, and many congratulations to both of you. A really interesting piece of work, and well done. I don't think you have questions that were sent to you beforehand, do you?
We've incorporated it into our script. So
okay, so there's no specific Q&A bit I have to cover. Thank you.
No, thank you.
You can. I'm winging this a little bit, so my apologies if it seems a little bit broken up. However, the last prize is to Beth Rooney, who has a connection with mental health and submitted this poem, which was the winner. We had, I think, 14 entries. This is something that's becoming more popular every year. And I'm going to try to read the poem out, which is going to be a little bit difficult, but just so that you can hear it. My dad always had this joke that he'd tell me. Why did the bike fall over when it travelled 2 miles? No, 3. And when he was here, that joke was always a favourite of mine, but now I can't remember the punchline. Day 1 and the phoning has just begun, and I accept scripted sympathy, although I'd rather have none. But maybe for someone other than me, it feels like some kind of healing, so I let it be. I lay in bed the whole afternoon and then watch the sun bow down to the moon. And I take its advice and bow down too, and I pray, because it doesn't feel like there's any more I can do. Day 2 and day 3 and day 4 are the same, bleak and dull and numb from pain. I stare at your face in the blue picture frame on my desk and notice the quiet. And somehow the earth still continues to spin, like it's not the end, it's all yet to begin. And somehow everything is so blissfully unaware of my screams and disbelief and exhaustive despair. And somehow everything, and it seems without care, just carries on. 1 week a routine as normal as I can make it, though when I wake up I plea I'm not really awake it. Really seems like you'll come back with a shudder and a shake. And I shudder and I shake as I realize I'm being fictitious. I pretend it's like when you used to go on those fishing trips when I was a kid. He'll come back soon, and you always did. Come back. 1 month my plea turned into rage. Why did it have to happen and be this way? I'm angry that you left me, and you think it's okay. But I wish the anger could have gone on, because without it, I realized there really was no one to blame. And I learn I prefer the feeling of anger to pain. 6 months have been, and I return into proper routine. It's my birthday next week. I'm turning 19. And I wish you could have seen the last year of my teens. Not spending it with you, well, it feels like a mistake, because you're the funniest person I know and the one that makes my heart ache. Today I remembered the punchline of your joke, why the bike fell over. It wasn't because it had broke, it was too tired. And when I had fallen, I wasn't broken. I was drained and tired, and it made me short-spoken. And with the time to heal and find peace and to bloom, I could now go on, I could now resume. But resume not quite the same as before, because I learned to love that little bit more. And most of all, despite all the pain, I learned to really laugh again. So thank you, Beth, for that very beautiful and emotional poem. That concludes our prize presentations for the South East Division. I imagine London are still continuing at present. The plan is that we convene back together at 3:20 promptly, so that we can have our final talk, which is destined, I think, to be another wonderful presentation, because Professor Andrea Cipriani is known to many of us. I'm sure we've heard him before, many of us, and he's speaking about updates in treatment-resistant depression. So you have a little bit of time now if you need a comfort break or to grab a cup of tea for the final excellent session of the day. Thank you everybody for attending the prize presentations. It's been great to have you involved in this. Thanks again to all the judges. They do put in effort to look through everything. And most of all, thank you to those who submitted the entries. Really high quality, really exciting, more posters than we've ever had before. And we will give it a good think over the next 6 months, what our prizes could be and should be for the next year. Thank you ever so much.